Alright, so today we're going to be talking about atrial fibrillation. This is a very important topic. One of the most important topics actually when it comes to medicine. This is one of the few topics that we did not cover in the cardiology board review that we did earlier. So I'm going to cover it now. Once again, my name is Mohammed Allo, cardiologist, Midwestern University. You can follow me on Facebook, Google+, Twitter, anywhere you'd like on the internet. But basically, atrial fibrillation, just briefly, you all know about it. It's the most common arrhythmia in the United States. Approximately 2.7 or 3 million people have it. And it's basically an irregular heartbeat. And if you don't know what that means, most of the time your heart beats boom, 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 boom. And in this case, it would be all over the place, like boom, 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 boom. And there'd be short distances between beats, long distances between beats, 3, 4 in a row, then a stop. But basically, that's how you recognize it. So what are the symptoms? A lot of people wonder, how do I know if I have this? Well, most of the time there are no symptoms. It's asymptomatic. There's no symptoms, and most people don't even know they have it. But sometimes they're very subtle symptoms. Some people have easy fatigability, where you used to be able to mow the lawn or walk up a flight of stairs, and now you can't. You just get more tired than the average person. The other symptom that people get, sometimes you get really short of breath. You get what's called dyspnea. Now this may be all the time you're feeling short of breath, or when you exert yourself you feel short of breath. The other thing is activity intolerance, sort of like easy fatigability. When you get up to do something, you just can't take it like you used to. Some people notice palpitations. Palpitations simply means you notice your heart beating, and some people notice it. And it really doesn't matter what rate it is. Most of the time you feel palpitations when your heart is racing, but it can be almost any rate people notice their heart rate. But when it gets really, really high rates is when usually people notice it. And if your heart is beating over 140, 150 all the time, then usually you'll notice it. Now, of course, there's the rare occasion of people who don't. So this is what it looks like. If you notice, you look at it carefully, you don't see any P waves, and then you see beats all over the place. If you look at the first 2 beats, they're closer together than the distance between the second one and the third one. Then there's a few more that are even closer together, and so on and so forth. You don't have a regular pattern. It's called irregularly irregular. So atrial fibrillation breaks down, into 2 basic treatment categories. The most important thing we need is an ultrasound of the heart, or an echocardiogram. We need to know, does the patient have a normal ejection fraction or a low ejection fraction? And this makes it really, really simple to treat atrial fibrillation. For everybody with a normal ejection fraction, you have to put them on medications to control their heart rate. Usually metoprolol by itself does the trick, and if it doesn't, you can add cardizem to it. If they have a low ejection fraction, you can put them on metoprolol, which they should be on a beta blocker anyways, as well as digoxin to help improve their contractility and improve that ejection fraction. There's absolutely no role for digoxin in atrial fibrillation for somebody who has a normal ejection fraction. Now, a lot of doctors add it on to metoprolol or whatnot. That's really old school thinking, and it really shouldn't be done. But a lot of times people are comfortable with what they know, and so they stick to it. So this is your basic breakdown. Anytime you see a patient with AFib, you got to know, do they have a normal ejection fraction or a low ejection fraction, and you could choose the drugs based on that. The next most important step is, do you want to rate control them or rhythm control them? Rate control is simple. You put them on rate control medications, and you just try to slow their heart down. Rhythm control, you try to get them back in rhythm, whether it's through medications or by electric shock or cardioversion, but you want to try to put them back in rhythm. So the rate control drugs are pretty simple. They were on that previous slide. You can use beta blockers, calcium channel blockers that are non-dihydropyridones, like diltiazem or verapamil. We try to avoid verapamil, but diltiazem or cardizem is a very good medication, as well as metoprolol, neither of which should drop your blood pressure. At very high doses, diltiazem can. They both function mainly as AV nodal blocking agents and not vasodilators. They should work really, really well. And you can also add digoxin if they have a low ejection fraction. That's considered the rate control arm. The other arm is the rhythm control. There's 6 medications that we could put people on for rhythm control. And these are the PO medications. Sure, there are a lot of other things that you can give IV, but for PO medications and long-term outpatient care, you have amiodarone, sotalol, flecainide, dofetilide, or Ticacin, propafenone, and dronetadrone. These are your options, and we'll get into a little bit about that in a second. So rate control is easy. You put them on those drugs, get their heart rate down around 70, 80, when they exert themselves maybe up to 100 or 110, and you just move on. With rhythm control, it's a little tricky. You have these 6 medications, but how do you know which one to pick? How do you know if you're going to put them on amiodarone versus sotalol versus flecainide? Well, there's a little algorithm you can use. Before we get to that, the AFIRM trial was a study back in 2002. They had 4,000 patients, or just over 4,000 patients. They had 2 arms, one rate control arm and one rhythm control arm. The rhythm control group that they put back in sinus rhythm were allowed to stop the Coumadin after 4 weeks if they wanted to. The rate control group actually ended up having better mortality overall, especially if the patients were over 65 and did not have CHF. And for both groups, the stroke rate was the same, about 1% per year. So rate control in this case showed improved mortality, but ultimately the AFIRM trial showed no difference. A lot of times in the past we thought that when somebody has atrial fibrillation, you have to do everything you can to get them back in rhythm, and that's just not the case. They both do well. Rate control is just as good as rhythm control. So back to our 6 drugs here. How do you know which ones to pick or what to put them on? So here's a simple updated guideline from 2011. So the most important thing, if you look here on the left, is to find out, do they have heart disease or not? And by heart disease, we mean, do they have coronary artery disease? Do they have hypertension with LVH, or do they have heart failure? Those are the 3 things you want to worry about. If they have no heart disease or minimal heart disease, you have almost any option you want. Any of those 6 drugs will work. We try to avoid amiodarone in younger patients. If they're under 70, they're still in their 40s, 50s, 60s, we try to avoid amiodarone. And if they're younger, we try to do an ablation. You know, well, actually, almost in any patient, we actually try to do an ablation. Why keep somebody in atrial fibrillation when we have ways to get rid of it? Now, if they're asymptomatic and it's not bothering them, then there's no reason to ablate it. But we try to avoid amiodarone until the patients are older, because the longer you're on amiodarone, the more the toxicities build up. So those are your options. If you have no heart disease, you can start with Multac or dronetadrone, flecainide, propafenone, sotalol, and then eventually amiodarone or Ticacin. But that's kind of the algorithm you should use. Ticacin is actually a very nice drug, and it's expensive though. That's why some of the other ones are rated higher than it. The next question is if they have hypertension. If they have a lot of LVH, and we're not talking 1.3, 1.1, 1.2 centimeters, we're talking over 1.3. If they have significant LVH, then you're stuck. You have to treat them like a heart failure patient, and you can only basically put them on amiodarone. If they don't have LVH and they're just regularly hypertensive, just pick whatever you want. If they have coronary artery disease, propafenone and flecainide are contraindicated. There was the CAST trial where they used similar medications to flecainide and propafenone, put people on it, mortality increased. So if they have coronary artery disease, you're very limited. You could use sotalol, which is basically a beta blocker, but it has some class 3 antiarrhythmic properties. You could use Ticacin, dronetadrone, and amiodarone, or you can ablate them. If they have heart failure, you're very limited. You can use amiodarone or Ticacin, or amiodarone and dofetilide. Those are your only 2 options in that case. So This is kind of a guideline, you know, print it out, put it in your pocket. You should know what to do when you're on a cardiology rotation, which drugs are your options and which ones are not. But it's a very good breakdown. So now it comes down to, all right, so what if I have a patient with very bad kidney disease? Which drugs are cleared by the kidney? Which drugs are cleared by the liver? So the ones that are cleared by the kidney are basically Ticasin and Sotalol. If you have a patient with poor kidney function, avoid Ticasin and avoid Sotalol. Flecainide is 30% cleared by the kidney, 70% liver. On the liver side is almost all the other drugs, amiodarone, flecainide, propafenone, and dronabinol. If they have liver cirrhosis or any kind of liver disease that prevents processing or clearing of medications, and you want to avoid those drugs. So that's kind of your breakdown. You have to choose based on your patient's level of heart disease, what type of heart disease they have or don't have, and whether or not they have liver or kidney disease. Now, if they're young and they don't have heart disease, they don't have hypertension, heart failure, coronary disease, nothing, you can pick whatever you want, really. So that's kind of how it breaks down. The other question that comes up very frequently is anticoagulation. So a normal person after age 75 has about a 1% chance per year to have a stroke. People with atrial fibrillation are at 5% chance if they're not anticoagulated. So while 5% per year is not very high, it's still 5 times higher than the normal person. So the key is to pick an anticoagulant drug to help prevent strokes. The reason they get clots is because the top 2 chambers aren't contracting. Atrial fibrillation is where the top 2 chambers just fibrillate. So blood clots can form on the left side and eventually be dislodged and give you a stroke. It used to be, up until the last few years, that we only had Coumadin as a choice, but now we have 3 other options. So Coumadin is very simple. It's a vitamin K antagonist. It antagonizes vitamin K. It takes a while to deplete your vitamin K, and then your vitamin K dependent cofactors 10, 9, 7, 2, CNS are all depleted, and then your INR goes up. So that's how Coumadin works. It takes about 5 days to know how much that dose is going to affect you. So if you start somebody on 5 milligrams a day for 5 days, don't check an INR till like the 4th or 5th day. And it really takes about 2 weeks total to get the to know what the person's INR is going to be on that dose of Coumadin. So if they're on 5 milligrams for at least 2 weeks, and then you check an INR, that's what their INR is going to be on that dose of Coumadin. So that's very, very important to keep in mind. Coumadin is very, very cheap, and for that reason, lots of people are still on it. You do want to avoid your dark green leafy vegetables, and I don't like to tell patients to avoid them. I like my patients to eat dark green leafy vegetables. I just tell them try to eat a similar amount every day or every week or however often you eat it. If you like your spinach or collard greens or kale, just eat the same amount every day. We'll adjust your Coumadin accordingly. The other drug that came out after Coumadin, there's 3. Dabigatran came out first, then rivaroxaban, and now apixaban. But dabigatran, just going from bottom to top, dabigatran is a direct thrombin inhibitor. It's called Pradaxa. It's 150 milligrams twice a day is the dose. The next one that came out was rivaroxaban, which is Xarelto, 20 milligrams once a day. It's a factor 10A inhibitor. The next one that came after that is called Eliquis or apixaban. It's a 5 milligram twice a day factor 10A inhibitor. Very novel studies. You should know some of the side effects you can get with these, and also how to reverse them if at all possible. Anybody know how to reverse dabigatran? Okay, a couple of people in the back saying you can't. One person says dialysis. Okay, good. How do you reverse rivaroxaban or apixaban? Sure, somebody says you can wait. Okay, good. Well, we'll see in a second here. So Coumadin is very easy. If you need to reverse it immediately, you can transfuse FFPs. Now, FFPs, fresh frozen plasma, When the FFP is being transfused, your INR is 1. So if somebody needs a colonoscopy or a procedure of some sort and their INR is 3.5 and they don't want to do it, or 2.8, start infusing FFPs, go do the procedure. Throughout the procedure, they'll be 1.0. When they come back, their INR, shortly after the procedure, shortly after the FFP is done transfusing, will come down, but it'll go right back up, close to where it was. So if they're 3.5, infuse some FFPs, 4 units, they get their colonoscopy done. A few hours later, the next day you check it, it's down to like 2.8. Now, so it brings it down, but not a whole lot. If you have time and you're just trying to reverse it slowly over time, vitamin K is how you reverse a vitamin K antagonist. You give somebody vitamin K. Now, a lot of times people don't realize where vitamin K comes from. It comes from the bacteria in your guts. So if somebody's put on antibiotics for a pneumonia or bronchitis or whatever it might be, UTI, and you deplete the bacteria in your guts, your vitamin K levels are going to go down and your INR is going to go up. So keep that in mind when you're treating patients. The other question comes up a lot about Coumadin is the lab called and said this patient's Coumadin is 7.5, or we're in the hospital, there's an ICU patient and their Coumadin is greater than 12. If the patient is not actually bleeding and their hemoglobins are stable, you do not have to rush to try to reverse elevated INRs. You can just wait it out. It doesn't take very long, and it will come down. So there's no reason to rush to reverse these if there's no obvious signs of bleeding and the patient is stable. The next one is dabigatran or Pradaxa. It is a shorter half-life. It's 150 milligrams twice a day. So you could wait it out if you have time, but if you don't, the only way to get rid of dabigatran is dialysis, which is important to know. So if somebody's on Pradaxa, dialysis will help. Another side effect of Pradaxa is dyspepsia. A lot of patients, about 14 to 20%, complain of stomach pain. That they say, my stomach just doesn't feel right. I wonder if I'm getting an ulcer. It's almost the feeling you get when you start taking PO steroids, but you get unusual dyspepsia. So in that case, you can switch them to one of the other ones. Apixaban and rivaroxaban, no real good way to reverse these. There's something called prothrombin complex concentrates, or PCC for short. It is not readily available, and the outcomes aren't perfect with it, but it does help. You can wait them out. For apixaban, it's 5 milligrams twice a day. You can kind of wait it out. Xarelto or rivaroxaban is a much longer half-life. You'll probably be waiting 2-3 days before that one gets low enough in your system. So they recommend that at least one hospital in each city have PCC. In case there's a big emergency, but even till now that's not readily available. So last but not least, actually in conclusion, that's pretty much how you treat atrial fibrillation, and a lot of the basic drugs and algorithms to use to decide what drugs to put them on and not put them on. If you have any questions, I'll be happy to take them right now. Yeah, go ahead. He brings up a good question. If somebody comes into the emergency room with a bleed and you're not sure when they took their last dose, it really depends on the medication. For example, Pradaxa and Eliquis, or Pradaxa and apixaban, because they're twice-a-day medications, monitor the patient, do CT scans of their head or whatever you think is bleeding. If it's an emergency, in the case of Pradaxa or dabigatran, you can do dialysis. With the others, call around and see if you can get some PCC. But that's all we really have for now. Okay. So his question is about Plavix, aspirin, and Coumadin. A lot of times patients have stents and they need aspirin, Coumadin, and Plavix. Let me ask you, what out of those 3 drugs, which one is most likely to cause a GI bleed? Okay, good. Half of you are saying aspirin and Plavix. Some of the others are saying Coumadin. So there's an important difference between platelet bleeding and factor bleeding, deep bleeding or superficial bleeding. Platelet bleeding is superficial bleeding. It's the faster bleeding where your body can quickly stop the bleeding. What affects that is aspirin and Plavix. That's what affects your platelets and the interaction between your platelets and the endothelial lining. So aspirin and Plavix affect your platelets. Coumadin it affects your cofactors, and it affects factor bleeding. Those are deep bleeds, usually like hemarthrosis or hematomas. It's not really superficial bleeds. All the other bleeds other than hemarthrosis and hematomas are generally superficial bleeds. GI bleeds, epistaxis, skin lacerations, bleeding in your head, any intracranial hemorrhage, vaginal bleeding from menstrual cycles. Almost any other bleeding is considered a superficial bleed. So those are from your aspirin and Plavix or any of the newer antiplatelet agents like Ticagrelor or Brilinta. So those so if somebody comes in with an intracranial hemorrhage and they're on aspirin and Plavix, those are both irreversible. So then in that case you want to transfuse them platelets, or if they need to go to surgery, they need to go to surgery. But you'll make the judgment call there. If they're on Coumadin and they come in with a GI bleed, it's probably not the Coumadin. It's always the aspirin or the Plavix, or both aspirin and Plavix, but it's not really the Coumadin that's the problem. But most of the time we'll stop all of them. In the case of a life-threatening bleed, you got to weigh the risk versus benefits, and in most cases we'll probably have to stop those or just choose to, depending on the patient and their situation. Okay, good. Any other questions? All right. Well, here's how you can get a hold of me, and I look forward to talking to you again.